Hello, I'm Dr Annalene Weston, Dentolegal Consultant at Dental Protection. Welcome to Risk Matters, our latest series of podcasts. As the name suggests, Risk Matters is all about managing risk, and in this podcast series, we'll be taking your feedback and queries and putting them to leading industry experts, getting them to answer the difficult questions about managing risk and working safely. It's about what to do when managing risk matters most. Now, in this edition, I'm thrilled to be chatting with Dr Saskia Salvestro. Hi, Saskia, how are you?
Hi, good, thank you, Annalene. Thrilled to be here too.
Thanks, lovely. That's great. And we're going to be revisiting MRONJ today. So I want to introduce Saskia first, and then I'm going to explain how this came about. So Dr Saskia Salvestro is the principal dentist and founder of Docker Street Dental in Wagga Wagga with over a decade of clinical experience. Now, she's recognised for her expertise in modern dentistry and her commitment to advancing the profession. And alongside her practice, Saskia is actively involved in education and advocacy and teaching final year dental students at Charles Sturt, publishing articles and updates on evidence-based dentistry, and serving on the Australian Dental Association Advocacy Committee. She's a fellow of the International Academy of Aesthetics, the Australian Academy of Dental Facial Aesthetics, completing her membership to the Royal Australian College of Dental Surgeons. Very accomplished.
And you have to be in this profession. It's all about keeping things up to date. It's never ending.
You do. And you're in practice today. Hey, I can see that we're in your practice. Yeah. You're renovating at the moment, aren't you? How's that going?
Yes. Never ending trades, never ending headaches, but it's all good. It's all going to be done pretty soon, hopefully. So yeah,
that's
we'll get there.
Awesome. That's awesome. So I wanted to explain. So obviously Saskia and I know one another. And the reason that this came about is because Saskia kindly contributes to our publications. So for those of you who are members should be aware, but for any non-members listening, Dental Protection has 4 publications in Australia. So we have RiskWise, which is for general dental practitioners, and that's released biannually. Then we have TeamWise, which is for OHT therapists, hygienists, which is released annually. We also have a dental student publication. And then we have one called the Young Dentist, or the Young Dental Practitioner, which is for young dental practitioners. And Saskia wrote a fantastic article on MRONJ for this year's edition. And when I was editing it, it occurred to me that while it was super helpful as a resource for the recent graduates, we probably all need to revisit MRONJ from time to time. So Saskia kindly agreed to have a chat with me about this now. So thanks, lovely.
Thanks. I couldn't pass up an opportunity to chat with the Annalene on a podcast. So
bless you,
I couldn't pass up.
So starting from the beginning, Saskia, for anyone listening, I'm sure we're all familiar with the terminology, but what is MRONJ?
So MRONJ, as we all probably know, is exposed bone in a jaw, bone that you can see clinically or bone that we can probe through a sinus tract that doesn't heal within 8 weeks. So on a patient follow-up after an extraction or if you see a patient and you see some exposed bone, it's within that 8-week period. The patient also needs to have a history or is currently taking bisphosphonates or anti-resorbative or anti-angiogenic medications and no history of head and neck radiation. So otherwise we'd be looking at radiation-induced necrosis of the jaw. So those sort of key factors need to tick those boxes, and often it is caused by trauma to the bone, either by some sort of traumatic dentoalveolar surgery or even by things like chronic trauma, like dentures rubbing on ridges for a prolonged period of time.
That's brilliant. Thank you. That's super helpful. So do you have any idea of the frequency?
I knew you'd ask me this. So I jotted down a couple of stats from a systematic review and meta-analysis in 2021. The very abbreviated version pretty much is that oral bisphosphonates aren't as risky, the ones that are taken for osteoporosis. So your things like Prolia or your Fosamax. 1 in 10,000 to 100,000 per year, patients per year. When you skip to the higher dose IV bisphosphonates that are taken patients with cancer and any sort of anti-angiogenics, it jumps up, the risk jumps up to 1 to 10% of those patients. So in general practice, it's far more common to see patients who are on the medications, and you see that list of medications, but you might not see the actual condition very often. So it is quite a rare condition. However, there is a few points here that I did want to bring up that we'll probably discuss a bit later, Annalene, but with the statistics, patients who are on dual therapy, and this is from this systematic review, patients who are on sort of dual therapy, like any combination drug, the risk does increase. So patients who are on bisphosphonates and also on things like corticosteroids or anti-angiogenics and corticosteroids. So there's one line here that says patients who went from pamidronate to zoledronate had nearly a 1 in 5 chance of MRONJ. So they're switching drugs, not just staying on the one drug, about 19% prevalence, compared with only 1% who stayed on that same drug at the same time. More than half were linked to dental extractions. About 60% of these lesions affected the mandible rather than the maxilla. And then we've got another statistic about anti-resorbative drugs. So patients are on dual anti-resorbative drugs and corticosteroids, like I just said, have a higher risk. There's not a percentage here though. So that's pretty much all I found at this stage. But
That's super helpful. Thank you. Do you see it much in your practice?
I'll be honest, I haven't seen the condition intraorally at all. I've suspected it, but it didn't end up being the condition. All the time, though, very, very often, I do see the drug come up, or a drug, either an anti-resorbative, an anti-angiogenic, or a bisphosphonate, even a corticosteroid, linked to that use in a patient's medical history. And the scary thing about these medications is that a lot of anti-resorbative medications now used for IV cancer patients have really weird names, and often we don't learn that sort of stuff at university, and because we don't update our knowledge on those medications very often, because we're not really I don't really read much about IV cancer therapy, the names can be a little bit confusing. So I always just, if I suspect something, I always just type the name into Google and see what the drug actually is and the mechanism of action and the class of the drug. And just the fact that, if you're able to flag that and think, okay, I don't know this drug, I'm going to look it up just in case, that increases the safety of your patient and lowers the risk of you potentially doing something that you might not do if you had known what the drug is.
Thanks, lovely. So I know that there are some with tricky names, but starting from the beginning, which are the common drugs practitioners need to look out for? I think it's a good refresher.
Yeah, so I tend to classify drugs linked to MORNJ in 3 sort of subheadings to make it easier for myself. The first one is your bisphosphonates, so the ones that are used for osteoporosis, your alendronate Fosamax, and then your IV version, which is your zoledronic acid. And then also you've got your rank L inhibitors, so your Prolia, denosumab. A lot of postmenopausal women are prescribed that for osteoporosis. So again, that's a higher risk bracket we should be looking out for. And then there's also your anti-resorbative drugs. So you've got your anti-angiogenic drugs, monoclonal antibodies, for example. And I had to actually write down how to pronounce this drug because I get stuck every time. Bevacizumab, or avastatin is your IV version of that one. And and these particular anti-angiogenics, these monoclonal antibodies actually inhibit the vascular supply of that healing bone, and therefore you get that decreased rate of healing after traumatic injury to that bone. So the other class of drugs are your tyrosine kinase inhibitors, which fall under that other drug category of anti-angiogenic therapies. And these ones are not commonly noted in patient medical histories. Some names of them, leventinib, sunitinib, and imatinib. Again, like, I'm not very familiar with them, so I had to write those names down. But these are the kinds of things that patients might not list on their medical history, but they are quite risky for MORNJ risk. And then you also have in that other class of drugs your corticosteroids, so things like your dexamethasone, your prednisone. They used in combination with any of those anti-angiogenics, anti-resorbatives, bisphosphonates can actually put the patient's risk of MONJ higher. So there's your sort
Yeah.
of 3 categories.
Okay, that's super helpful. And it's funny because with some of those drugs, those names that are unfamiliar, those tricky names,
Yeah,
you're having to look them up because they are so
I had to write them down.
unfamiliar. And yet the DEX, we see patients on that all the time.
Yeah, all the time. Yeah, and the thing with dexamethasone and those other corticosteroids is that they suppress the immune system, so that patient is predisposed to not healing properly. So if you induce trauma, then we don't often link corticosteroids to potentially that risk of the bone not healing and becoming necrotic. So yeah,
Yeah. Yeah.
interesting.
So it's more that interference with healing that causes the issue.
Yeah.
Okay, brilliant. So you mentioned some of the tricky drugs or the ones that were poorly known. So if we were to look at it the other way, then what conditions are these patients being treated for? That so if the patient may not know the name of the drug or declare the drug, but what condition then would they be being treated for? You mentioned that there are some cancer patients.
Yeah, so cancer patients receiving IV therapy for cancer. I've actually had to write down the type of cancer treatment. So patients with things like multiple myeloma, I've seen multiple myeloma in patients' medical history a couple of times, and then they don't write down exactly what they're taking for it or being treated for it. Prostate cancer, breast cancer, um, also with osteoporosis, a lot of postmenopausal women will say they have osteoporosis, but won't actually say that they are on some sort of bisphosphonate or anti-resorbative therapy. So you just got to sort of ask the patient if they listed there, are they taking anything for that condition?
Yeah. And so I think then things that affect our healing and things that affect our bone turnover, those are the things that we need to sort of be triggering.
Absolutely, yeah.
I had a patient in her 80s and she had multiple infected teeth. And she did her medical history for me. And she said, look, I'm just on these tablets for my blood pressure. That's all I'm on. She was absolutely adamant. She didn't speak English as a first language. She was absolutely adamant that that's all that she took. Okay.
Mm.
And so I took some radiographs. So, because I needed to see what was going on with these painful teeth. And I was having a look at them and I thought, geez, she got some good bone for 80. Oh, and so I went through again and I said to her, do you go, and I always say of not just tablets or medicines, but I do say injections, things you see a doctor for regularly, any
Mm.
injections, because I find that sometimes people don't make that connection with Prolia because it's not a medication they take and because it's
Mhm.
administered relatively infrequently that they won't necessarily. So I mentioned that to her again and she was like, no, absolutely not. And I said, look, I need to, is it okay if I speak to your doctor?
Mm.
Because I need to make sure that there's nothing that I'm going to do that potentially could make you poorly. She was absolutely fine about it. And I rang the doctor and I said, so she's declared whatever. And he was like, and the list of medications this lady was on, including Prolia, but also it brought to mind that there was actually a capacity issue there as well. Because it wasn't that she didn't know she was taking those medications it was that she didn't know she was taking those she didn't have that recollection. The one that she took every day for her blood pressure, which is one she'd been taking for years, that was the one that she could remember. So she was
Mm.
mindlessly taking these medications every day, but not necessarily remembering that she had there was a whole lot to unpack with this particular patient. But I will
Mm.
always be very grateful that I took those x-rays and went, wow, some good bone.
Yep.
Oh.
It's amazing, isn't it? Like, I can't count on two hands how many times I've asked the patient about their medications and medical conditions and their medical history, and they don't actually know what medications they're taking or what it's for. So it it's amazing. It just shows that the importance of prevention and the importance of going through those clinical processes and taking your medical history and, doing your diagnostic workups and taking those precautions, contacting the GP. It's really important.
And I think as well, when people are doing that, they're not trying to be difficult. And it's not that they're
No.
stupid
Yeah.
or they're being obstructive. It's that we're all busy people. And when something's part of your routine, sometimes people just don't remember. And I think they
Mm,
often don't realize the relevance. Even if we explain the relevance, they think that's doctor stuff, not
mm,
dentist stuff. And they don't see that the two could connect. So I think there's some
mm.
helpful lessons there for all of us. Thank you.
Yeah, definitely, definitely. And these tricky drugs, the ones that we that can create issues and put patients at risk of medication-related osteonecrosis. We as dentists, we just don't recognise drugs like that. Those oncology drugs like the bevacizumab, for example. I mean, do you think a patient? I don't believe a patient would even recognise that name or have it down in their medical history unless they were really, really diligent. So follow-up questions, even just making sure you understand what other medications are you on taking over the counter? Because sometimes even patients think steroids are over the
Yeah.
counter drugs. And, once you get that combination therapy happening, that's when you start to think, okay, if I need to ever do any traumatic surgery on this patient, even perio treatment, or if the
Yeah.
patient has a denture, um, that patient's really at risk. Yeah.
Yeah. No, that's really helpful. Thank you.
Yeah.
So, apart from that thorough medical history taking, and
Mm.
perhaps looking at it from both sides, taking the medication history, remembering that there can be, my understanding from what you were saying, is this combination therapy increasing the risk. So, it's like an accelerator or an accumulator. The patient's on one drug, but if the patient's on two or three drugs that can be linked, it's going to amplify their risk.
Mm.
Looking at it the other way then, and when we're taking the patient's medical history, really considering the conditions and the patient acknowledging that the patient might not be on top of their drugs that they're on, particularly if they've got tricky names, but knowing that certain conditions should flag with us. Um, I think applying a bit of common sense, like my lady with the, gee, she's got good bone.
Yeah.
And it's funny, how you think these things. And it was literally, that was my thought, gee, that's some good bone. Anyway, so what else then? You mentioned dentoalveolar trauma. I want to talk
Mhm.
about dentures in a moment,
Mhm.
but what are the other things that we as clinicians we can do to decrease the likelihood of a patient experiencing MRONJ?
So, patient-related factors, other risk factors that predispose that patient or increase their risk, things like the patient's age. MRONJ is linked a lot more to elderly patients. The patient's sex, so if they're male or female, because females are predisposed to the condition with estrogen, low estrogen, and osteoporosis being higher in postmenopausal women.
It's all part and parcel. I'm afraid, Saskia, you've got all this to look forward to, my friend.
Exactly.
Sorry, carry on.
So, so those sort of systemic risk factors. Also, if they have any other comorbidities like diabetes, which obviously impairs your healing, other immunosuppression, um, poor oral hygiene. Are they a smoker? Because we all know that smoking decreases the blood supply to the oral cavity and decreases healing. That's why our gums don't bleed when we're probing if we smoke. So all of that sort of stuff is important to add into that risk analysis of the patient. That's one of the things I look for, but typically I do look for three things when assessing a patient for anything really. But for MRONJ, it is quite important. So you have your patient factors. We've talked about the drug-related factors, and another important thing with the drug-related factors are that you actually ask the patient, even if there's nothing on the medical history, have you ever taken any injections for your bones? Have you ever been on any bisphosphonates or anything like that? Because sometimes patients may have finished a therapy and not be on that drug anymore. But as we know, that alendronate does stay in the bone for quite a long time. Prolia not so much. But we've just got to make sure that we actually take a drug history, not just a current drug history, if that makes any sense, because
Yeah,
these
that's really
drugs do stick
helpful,
around.
actually. It's a great point. That is a great
Yeah.
point because they might not be on the active therapy, but as you said, it could be hanging around.
Yeah, literally. They might have stopped it last week and now they
Mhm.
think it's not necessary to put on their medical history, and that's not
Yeah.
their fault. It's important for us so to ask them. Um, and also when they're next, if they're taking these injections or they're going to get these injections, it's important under that drug related factors bracket, two of the three things, um, when their next injection is, like when they take their injections, because often it is beneficial. It's not beneficial to ever ask a patient to stop the drug that they're taking, especially with these types of drugs. It doesn't, nowadays the research says that it just doesn't really make much of a difference. But for some drugs, such as your IV patients who are more at risk, obviously, of developing MRONJ, they are more at risk. Taking that history of when their next injection is allows you to maybe time a simple extraction or an atraumatic extraction close as possible to their next injection, which means that drug is going to be at its lowest point in their
Yeah.
system. Yeah.
Yeah. No, that's really
Um,
helpful. So timing's important too. And you
timing,
mentioned
very important.
atraumatic extractions. I love that
Yeah.
phrase. But
Yeah.
I know what you mean by that. But can you tell our viewers and listeners what you mean by an atraumatic extraction?
Atraumatic extraction, as in you're not going to go and drop a grenade in that patient's mouth. You're literally just simply luxating that tooth out, not removing any bone, not surgically interfering with the patient's soft tissues, bone and jaw. You're simply just using forceps and other instruments to remove that tooth without surgically removing any bone. You're not taking out a handpiece. Awesome MORNJs. Yeah.
So you mentioned perio surgery earlier as well. So soft tissue disruption can be
Mm.
problematic also?
Yeah, I'm just going to throw in here, I'm not an expert in this field, so
Oh, that's okay, hon.
I'm not trying to be. I'm definitely not an industry expert, but yes, soft tissue with perio surgery. Obviously, perio involves when patients switch over from gingivitis to perio. That's when it involves the alveolar bone. And we need to be very careful with perio patients surgically and non-surgically when we're debriding teeth, that we're not inducing a lot of trauma down near the alveolar bone. Even things like leaving residual calculus in pockets that can induce inflammation afterwards is important. So prescribing them a mouth rinse, like chlorhexidine-based mouth rinse afterwards, is great to reduce that risk of infection. So yeah, just you think perio is a quite simple procedure in a dentist's eyes for scaling and root planing, but it might not be to a patient who's on these types of medications.
No, it's a really helpful reminder. Thank you.
Mm.
Now, I said I wanted to pick up on dentures separately, and it's
Yeah.
because I know you and I have discussed this, but I saw for the first time, so I've been a dental legal consultant for 15 years now, and some days it feels like it, and others it doesn't.
I don't know how you do it. Yeah.
With a smile.
You're a
Uh,
saint. Yeah.
Thank you. I don't feel like it, but thank you. But I saw something which I'd never seen before in a case recently, and it's a
Mm.
patient who a had experienced MRONJ as a consequence of a denture. Now, to be clear, in this particular case, the denture itself was not ill-fitting. What had happened in
Okay.
this particular case is the patient was living in some sort of care facility, and the care facility were not removing the patient's denture to clean it or clean the teeth, okay? And this is a common thing. It's sad, but let's be honest, none of us are going to roll over with surprise. It's not like we've never heard that before.
Mhm.
And what had happened was, to the best of our understanding, something had got underneath that denture and had sat there for a really long time. And I don't mean something soft, I mean something hard. who knows what and had sat
Yeah.
under there for a period of time. And essentially, every time the patient had bitten in, imagine it being like a stone in your shoe. So the denture was acting like the shoe, and it was pushing the stone into the foot, pushing the stone into the patient's gum. So what was essentially happening is that patient experienced MRONJ, and I had never, ever, ever seen that before. But my understanding is that ill-fitting dentures, for example, so as I said, in all fairness, this was not an ill-fitting denture. It was a well-fitting denture where trauma was experienced due to the presence of a foreign particle. But ill-fitting dentures are commonly occurring or are a risk factor, aren't they?
Definitely. Yeah, definitely. Ill-fitting dentures fall under, as I said, those three things that I look out for when risk assessing a patient. The third thing is dental factors. So that chronic trauma that's constant is going to cause some sort of risk of some complication, and that includes MRONJ. Yeah.
Yeah. And that's
Yeah.
so sad. Like, I felt so sad for that patient because
Mm,
that's no one, and that's no one's fault, bless her. Well, you know what I mean by that. Like,
I
it
do.
it's and I felt really sorry for the dentist as well, because this patient presented with toothache under the denture, and she'd had
Mm.
toothache under the denture for some time, and they took the denture out, and there it was, and it was just, yeah. Okay, so let's just
I
say,
mean, who knows, Annalene? You never know. It could have been a bit of calculus, and some calculus can be really hard. There's that
yeah.
subgingival stuff is really tenacious, so it could have even been something like that that fell off and got stuck.
Yeah, could have been anything. And I
Yeah,
think, yeah.
yeah.
So let's just be that dentist then.
Mm,
Patients presented doesn't have to be because of treatment we've done, doesn't have to be from a recent extraction. Patient comes
mm,
into your surgery this afternoon. You'd be like, no, thank you. I don't want to have to manage this. But okay, patient comes
yeah.
into your surgery this afternoon, Saskia, and they take their denture out, say, and that you check their medical history, and it's this patient that we're just talking about, and you
Mhm,
suspect MRONJ. What are you
mhm.
going to do? What can we as general practitioners do? Or is that a terrible example because it's gone too far?
No, not at all. Obviously, as GDPs, we're that first line of patient contact. Patients aren't
Yeah.
going to go straight to an oral surgeon when they have a denture problem. So they'll most likely be coming to us. Um, Obviously going through that clinical process, like we've always been taught to do, risk assessing the patient, taking their meds, taking their social and dental histories. And then if you do suspect that it is MRONJ and it ticks those boxes, um, then you have to sort of start to think, is this case within my, and this is a really important topic actually, within my individual scope, or is it within my professional scope as a dentist? Do I have enough experience, even though I'm taught about it, do I have enough experience to manage this case, whether it be surgically or non-surgically or supportively? That's a really important thing as a new graduate, especially, to assess with every single case that you get. Are you able to manage it? So say you are able to manage a part of it at that appointment and you want to get the patient out of pain. You would obviously identify what's wrong, identify the bone. Prevention, obviously, is definitely the cornerstone of this sort of treatment. But if suspected, you're going to make sure you avoid those potentially invasive procedures. You want to keep the area very, very clean. Maybe prescribe that patient an antimicrobial mouth rinse, maybe some pain relief as well, and some antibiotics. Um, Improve their oral hygiene, like improve those supportive factors that lower the patient's risk of MRONJ. And that also might involve a multidisciplinary approach for that patient. So educating not only the patient, but their family and maybe their carers if
Yeah.
they're in a nursing home. I'm not too familiar with nursing homes. You might have to speak to Dr. Mark Wotherspoon more about that sort of geriatric side of dentistry. But yeah, it's really important to get that first line of prevention under control. Otherwise, it'll just keep happening again. You can treat the issue at hand, but you don't want to. You want to prevent it from happening again. So taking the denture out at night is probably the main thing,
That
keeping things
patient, sure,
clean.
bless her. Yeah, bless her
Yeah,
heart.
and then obviously if it's not healing, say you're in a rural area and you don't have an oral surgeon handy and you can't contact one quickly to get an opinion with some intraoral photographs, you want to review that patient in 8 weeks' time, and that will sort of, with that 8-week period, that you'll sort of know, well, it is MRONJ or it's not. I've got to then intervene surgically and send this patient either myself if I'm capable of doing that. I'm certainly not. I have a really great relationship with my local oral surgeons, but I will be referring that patient to an oral surgeon to get that necrotic bone removed and debrided, and then again they just continue on that path of prevention, and hopefully it heals.
No, that's super helpful. Thank you. And you touch on, I think, a really important topic there that we often talk about in our publications and in our podcasts and webinars. You can't understate the importance of having a really good relationship with the people that you refer to. So having a referral network in the first instance of specialists, because however accomplished you are as a general practitioner, there are always going to be things that fall outside what you can manage. So that's the first thing, having like a really good relationship and having that good referral network, because you need to know where you can send these patients. And we're talking about MRONJ today, but this could be anything. This could be a root in the sinus. This could be a fractured file that you can't manage. This could be some pain that you don't understand. Having someone that you can refer to, knowing who those people are, is just such a helpful thing. And not just as a recent graduate, but also as a mature age practitioner, but definitely for recent graduates, get those referral networks set up. Go and meet your specialists. I always say this. Specialists, I find, are delighted if you ring them up and you're like, "Hi, I'm due to the area, or I've just graduated. Can I come and meet you? Can I come and see your surgery?" They love showing their facilities and they love meeting the people who are referring to them. And a lot of the Max Faxes that we speak with are delighted to actually take recent graduates sometimes into theatre with them if they can get those. Um, the credentialing and everything that needs to happen in place so they can actually come and observe and see what's going on as well. So, do avail yourself of those opportunities. I think sometimes, particularly young practitioners, are quite scared of specialists and they think that they're going to throw them under the bus, whatever that means. But um, no one's going to get cross with you for asking a question. Wouldn't you
Absolutely
agree?
not. No, and I think that's part of our profession, right? Our profession is this ever evolving profession. We have so many people who are experts in certain fields. It can get a bit daunting because things are always changing. Science is bringing out all of these new, you know, things for us to learn, and it's sometimes hard to keep up with, especially as a new graduate, because what you learn at university, often by the time you graduate, there's something new to learn. But yeah, the most important thing is to know that you are always a student. You're always going to be learning, even if you're 40 years out. And having a specialist who you can call or you can, refer to, and that they're there for you to support you, is a really, really great tool in your toolbox. And like you said, they appreciate it. They appreciate the communication, and the patients do too. The patients know that they're being safely managed. You want to be able to manage that patient safely. And if that is not something that you can handle as an individual practitioner, then absolutely you need to be referring.
No, that's fantastic. Thank you. And it sounds like 8 weeks is a bit of a critical number when we're considering referrals.
Yeah,
Fantastic.
yeah.
So, Saskia, that's been really informative. Is there any other advice or anything else that you'd like to share about this subject or any other subject while we're here?
Well, I've got lots of subjects that I love to talk about in dentistry, as you can see by all the article pictures I send you. But no, I'm sure we can maybe do this again with something else. But I guess
Absolutely.
touching back on MRONJ, I guess, I have three sort of key things that I just like to remember in terms of MRONJ, and that is risk assessment, not forgetting that risk assessment. And that goes for everything in dentistry. It might be for anticoagulant therapy. It might be for, diabetes. It's just that same risk assessment process that you do for every patient. And if you're doing that for every patient, then you're not going to miss something critical. If you think something looks funny or you don't know the name of something, by all means, the good thing is that you've noticed that. You've noticed that something isn't quite right. Google the name, look it up in your MIMS book. The fact that you're able to recognize that is the good thing. It's not about the fact that you don't know what it is. The second thing is communication is absolutely critical. Like we were just talking about, liaising with the patient's doctors, their GPs. It's a multidisciplinary communication pathway. Specialists and also maybe even endocrinologists, because sometimes patients who have rheumatoid arthritis are on corticosteroids, and they might also have osteoporosis. So looking out for those things, if a patient says, "Yeah, I have arthritis." Okay, what kind of arthritis is? Oh, it's rheumatoid arthritis, and I take a steroid, but it's not listed on the medical history. And I have osteoporosis. Okay, you taking medications for that? Yes, I am. So that sort of stuff, that communication, and then also the third thing is reassuring your patient, because really, ideally. I think what we need to take away as general dental practitioners is that MRONJ is a very low risk adverse event. It's hardly ever going to happen. Like I just said, I've actually never seen it. Thank goodness. But if I do, I am prepared. But it's not scary, and it's like we just talked about statistics. One in patients on oral bisphosphonates, 1 in 100,000 or something like that. That's very rare. So often you'll see the medications related to it. You'll see the medical conditions related to it, but you'll hardly ever see the actual physical condition itself. Dentures are at high risk. Obviously, you might see it for the first time with an ill-fitting denture. But yeah, and important to explain to the patient that the risk is there, but it's just a risk. And in the end, does the benefit of treatment outweigh the risk? Probably. Or the other way around, don't stop your medication, but it's not scary and we can manage you. And this is the way we're going to manage you. And then that way patients aren't scared of this, bone that's potentially going to die and cause all these problems. The fact sheets, have you seen the fact sheets that patients are given before they go on Prolia?
Yeah, they're exciting, aren't they?
Yeah. I think they definitely need that reassurance. So that's a really important third thing to take away.
Thank you so much, Saskia. I really appreciate your time.
Anytime. I hope we can do this again. It was fun.
Definitely. And thank you all for listening. We do hope that this podcast was helpful to you, and we look forward to sharing more guidance with you in the future. Also, I should mention, for those of you recent graduates, do keep an eye out for an article which accompanies this podcast in our recent Dental Practitioner publication. And in fact, even if you're not a member, have a look on our webpage. It might be that you can access some of those publications online and see not just that, but some of the other work that Saskia has done for us. And if you like Dental Protection podcasts and you'd like to hear more, please subscribe and leave a review.